let's start just historically with traditional surgical excision. We know that, at least in dermatology, one of the great things about being able to treat skin cancer is that it's readily accessible. It's on the skin. We can see it oftentimes, and there are clear signs and symptoms that something is not normal. And so we can use those as clues to discern what we need to remove on the skin, but our eyes are limited. And we know that because if we were to remove only what we saw on the surface of the skin, and that was representative of everything underneath the skin, we would have a perfect cure rate 100% of the time. And that's not the case, unfortunately. So with wide local excision, it's termed wide because we have to account for an additional, what we call margin or amount of skin around what we think may be the skin cancer. And I take that into account. It's almost our way of implementing a fudge factor, if you will. So for very common skin cancers, by far and away, number 1 and number 2, basal cell carcinoma and squamous cell carcinoma are the most common subtypes or types of skin cancer. And we have established very well-established guidelines on how much skin around the perceived tumor to take. And so somewhere that range is anywhere from 4 to 6 millimeters. And if you were really to take the opportunity to measure that out for yourself, when you're going around the entire perimeter of what is seen as skin cancer, that's quite a bit of extra surgery in order to have the confidence that you got something completely.